Hello. We have a small group, probably because I've changed the time several times for the start of this, so I'm sorry, I apologise for that. I'll just, while we're waiting, just share my screen. There we are. You can see that?
Yep.
Yep. Okay. How are you going, making your way through with the female reproductive organs? Okay.
Yep, getting there.
The drawings, the 2D diagrams can be rather confusing, particularly because the uterus is and the ovaries are actually quite variable in the positions that they can sit in the pelvis, and that can make it a little bit confusing. And then there's lots of ligaments and things that they attach to. So hopefully we'll unpack it here and, you know, make it so that it seems a little bit easier to understand. I've actually got to shoof off a bit earlier today, so I might get started a little bit earlier. It's recorded, so anyone that misses anything can watch the recording if they come in and we've started. So what we're going to go through is the ovaries, the uterus, and the ligaments of that to a very small degree. And the cervix is really part of the uterus, and that itself can be a little bit confusing because we talk about the cervix and the uterus different, sort of separately, but the cervix is considered part of the uterus, just what we call the distal part of the uterus, this part down here. So all of this is the uterus, but this cervix is this distal, meaning further away from the trunk of the body, part of the uterus. It's closer to the vagina. And then we'll talk about the fallopian tubes, which we can't see on this image, and then we'll talk about the vagina as well. We don't really see the fallopian tubes when we do imaging because it's like those ureters that we talked about that connect the kidneys down to the bladder. They're a collapsed tube, and they're like the ductus deferens in the male. How I said we don't really see that on imaging. And so think of the fallopian tubes as the same sort of size as those other tubes. And some of those really small tubes, we don't see them on imaging unless there's something wrong with them. But we have to know where they sit, because if there is something wrong with them, they're going to be there and be obvious. So we already have covered the urinary bladder. It looked like the cat head. The urethra, it's where the urine comes out from the bladder that we pee through. And we talked about more the rectum and anus, and then we talked about all of the male reproductive organs, ones that sat inside the pelvis and ones that sat external to the actual pelvis as well. If you want to look at some little tools that talk about the anatomical relationships, there are some little things in Complete Anatomy, and you can go through. It can label the structures for you. When you're looking at these images, always try to work out what's anterior. Look for your pubic symphysis area and think that's always anterior, and look for the sacrum and the end of the spine, and that should be posterior, and think of where structures sit from anterior to posterior and superior to inferior. So when we're talking about the female organs, as I said, we're talking about ovaries, uterus, these tubes, which on the diagram, the fallopian tubes, they look really big, but in reality, they're really, really small. I've just drawn them. This is just a drawing, sort of like the uterus, the fallopian tubes, the ovaries, the cervix and the vagina, so you can see where things sit relative to one another. This is sort of, it's not a straight coronal view because the uterus will tip into different angles, and we'll cover that shortly. But imagine if we stretched everything out, and this would be the right side of the body and this would be the left side. So this would be the right ovary and this would be the left ovary. It's important to know that the uterus has a cavity, and you sort of look at it and it looks all solid, but in reality there's actually a cavity in there, because inside this cavity is where the developing fetus in a pregnant person or a pregnant uterus will develop. And so it's a space that can hold the baby. And so that's important that you appreciate that, because on the images, when we look at it, you won't see the space. It will all be compressed down, but you need to know that there actually is a space there. Any questions about this or this diagram so far? I just tried to put not too many labels on there for you. So you have the uterine cavity, which is in the body of the uterus, and then the cervix has a canal, but we call that the cervical canal. And so when someone's pregnant, the baby needs to sit up in this uterine cavity. The baby should not sit in the cervical canal. It's a passageway in which the baby will exit and then exit through the vagina in a vaginal delivery. So even when someone's pregnant, the baby is maintained up in this uterine cavity, and this cervical canal should be closed. I've included some pictures from Draw It to Know It, more to make you remember to have a look at that and start drawing some of the pictures. It's nice and colourful, and it's got lots of labels there. Sometimes they look like they're too much, but I've included them for the notes if you didn't want to go through and and flick and get them. So it's important, when we looked at the male structures, we talked about looking at the structures from anterior to posterior, and we said there was a bladder. And what's that posterior to the bladder as the male reproductive organs?
Seminal vesicles.
The seminal vesicles, that's right. So this is a female mid-sagittal. This is a sagittal view, and we don't have seminal vesicles. There's no prostate, sort of inferior to the bladder. But we do have the uterus, the cervix, and the vagina here. And so the uterus, the cervix, and the vagina sits in between the bladder and the rectum. So B's for bladder, R's for rectum. The uterus has different components, as I've just mentioned. So what's the top part of the uterus called, this part up here?
Fundus.
The fundus. So F stands for fundus. B stands for body. And see the cervix, I've drawn it. This is just one of my dodgy drawings, but I've drawn the cervix in this area. And can you see it's just got a skinny canal? Whereas this, what I've called E, is endometrium, or it could be as well the uterine cavity as well. So you can see there's a cavity to this point, and then it becomes thin, and that becomes the cervical canal. Can you see that? And so that's going to be important to note, because this is going to be the cervix on this diagram here, and then this is going to be the body and the fundus of the uterus. The fundus is basically the muscly part that sits superior to where the endometrium sits and superior to where the uterine cavity sits. Is what I'm saying making sense there?
Yep.
Okay. So this is a mid-sagittal. We can see the spine at the back and the pelvic bone, or the symphysis pubis, probably pelvic bone here at the front. So this is anterior and this is posterior, this is superior and this is inferior. So we can see the urinary bladder and the urethra. We can see the uterus here, This is all the uterus. This bit that I'm circling here is going to be the region of the cervix. This bit here is going to be where we can see this stripe, which will be representing the endometrium, which lines the uterine cavity. This all represents the body of the uterus. And then above that, just this rounded semicircular muscly bit up the top, that's the fundus. Then from this point down is vagina. Can everyone pick those different parts? We're going to look at it over and over again. So if you're not getting it just now, don't worry, because you will hopefully have it by the time we're finished. Let's look on this diagram. This is probably going to be the body area of the uterus. This bit up here will be the fundus, the rounded muscly bit. And then this distal canal bit down here will be the cervix. And then this bit here will be the vagina. You can sort of think of the vagina as the vaginal canal as well, because it's a canal to allow the passageway and exit of a baby from the uterus when someone's having a baby. And we often refer to it as that as well. The uterus is, most of it is made up of muscle. And so whenever something has muscle in it, we use the term myo, so M-Y-O. So we have myometrium when we're talking about the muscly part of the uterus. If you get confused, you might have heard of myocardium. Someone has a myocardial infarction. That's like a heart attack, basically. And so that's the muscle part. The myocardium is the muscle of the heart. So the myometrium is the muscly part of the uterus. And so you're bringing together some of those anatomical words. The inner lining of the uterus here is called the endometrium. And then the very outside bit, very outside border of the uterus is called the perimetrium. And can you see myometrium, perimetrium, endometrium, they all have metrium in them? Yes, you've heard of endometriosis. And so that is where this is the endometrium. So endometriosis means this endometrium should be just sitting just inside the uterine cavity here. When someone has endometriosis, they have what we call ectopic areas of endometrium. So they can have endometrium that sits out in their abdominal cavity. It can sit in their bladder wall. It can sit in their bowel. And so when females have a cycle, this endometrium gets thicker and thicker throughout their 28-day cycle. And then when they have their period or menstruation, they shed it, which comes out through their vagina. The same thing happens if the endometrial tissue is outside the uterus. They will have the same shedding and building up and bleeding of that endometrium wherever it's sitting. So if it's in their abdominal cavity, or if it's on their bladder wall or in their bowel, they will get bleeding from that. And that can cause all sorts of scar tissue and things sticking together, and it becomes very, very, very painful. So yeah, so think of the metrium as things pertaining to the uterus. So in your text, you will have this picture, and I don't know about you, but I look at that and just go, oh, there's too many labels on it for me. It just goes a bit too much, which is where I try and break everything down. But this thing, they often say the uterus is like a pear. And so you can sort of see an upside down pear here, with the rounded bottom bit of the pear being the fundus. And you can see the very outside layer of that uterine tissue is the perimetrium. The thick muscly tissue is the myometrium, and the inner lining of it is called the endometrium. And they're just the three things that we've talked about here. You can see the fundus is just this, think where the little core thing is on the pear. It's going to be that rounded bottom bit, and then the stalk will probably be the vagina. I don't know, trying to give you a visual there. So in in your drawer to know it, you have this sort of a picture. And once again, it's got a lot of labels, but we will go through all of these things through this study group. You can see there's the fundus of the uterus, and you can see the body of the uterus comes down and it's in the region of the uterine cavity. Between the body and the cervix is an area called the isthmus. An isthmus is just an interconnecting bit. So it's just like a little bridge between two things. So don't worry too much about the isthmus, but it's important to note that there is a cervical canal, and that's in the region of this whole thing's called the cervix, and it's the inferior or distal portion of this whole uterus. Any questions so far? No? So we've got the uterine fundus, the body, the cervix and the vagina here, and you can see the isthmus is just the connection between the uterine cavity and the cervical canal in a way, and it's the connection between the uterine body and the cervix. So here's an MR. This bladder is not very full. This bladder probably has about, I don't know, say 10 or 15 mils of urine in it. And so if the bladder got bigger, it would sit up here and it would tip that uterus so that it would stand more up like this. This is what we call an anteverted uterus. And that means that this fundus, this rounded part of the uterus, is tipping towards the anterior part of the abdominal wall, the anterior part of the pelvis. What am I outlining here? What part of the uterus would you say this arrow is pointing to? Oops. Oh, I've got to use that. Thing. Let me just to make my okay. Can you see that better with the red, the dot? Okay. So what do you think this is pointing to? What part? How would you describe what that little dot is pointing to there?
Is that the body?
Body. Yeah.
Yeah, the body of the uterus and the myometrium in the body of the uterus. What do you think this bright area here is?
Yeah.
The endometrium. So the endometrium lines the endometrial cavity or the uterine cavity, but can you see it's all filled with endometrium because the cavity, the two walls of the cavity are squished together. We don't see the actual space in there. So this is all endometrium, and then this will be cervix. And see how you can't really see the cervical canal? Like the endometrium comes to this, and there's actually a cervical canal which runs through here, but we don't see a little white line there because it's closed. Does that make sense?
Is that because the bladder isn't full enough?
Oh, the cervix will always remain closed unless it opens to allow the shedded endometrium out in a non-pregnant uterus, or it should really just remain closed at all other times, really.
So can you see it if someone is on their period and you're ultrasounding them, like where they're shedding, or?
Not maybe. Yes, if someone's having a period at that point in time, we tend to see it if someone is having a miscarriage, like in action. So the contents of the uterine cavity is coming out through the cervix. We'll see it open then as well.
With the previous scan that you showed us, there was quite a lighter area where the cervix was. So yeah. I just assumed that it was because it was open in this one.
Yeah.
Or is that just a different type of tissue?
This person may be having, and sometimes you can get little artifacts in here, but maybe this person is having a period, and at the time the sequence was happening, there could be something going through there. And sometimes you get little cysts and things. That's probably a little cyst that we can get sitting in there as well.
Okay. Thank you.
Sometimes they can have changes that sit in the cervical wall as well. You get little cysts and things and changes. Good question.
So when you have a baby, is it your cervix that dilates?
Yes.
Yeah, okay.
Because it has to dilate to allow the baby to pass through. Yeah. And that's what we say, it dilates, because it normally should be shut. And I'll show you some pictures. We do ultrasounds and have to check the length of the cervix when someone's pregnant and make sure that it is closed. Because if the cervix shortens in length, there's a chance that the person may have a premature delivery, because it needs to be a certain length to maintain the baby up into the uterine cavity.
So when you say shortens, do you mean like it's short from the body down to the vagina?
This length would be the cervix. And so instead of this, it might be like that length from what I'm showing here.
Yeah. Okay, cool, thanks.
Yeah.
And would you see like a IUD on those sort of images at all?
Yeah, you can definitely see an IUD. For those that don't understand what that is, that's an intrauterine device. It's an acronym that stands for that. An intrauterine device is something that's implanted. There's one called the Marina, and it's implanted and it's put in this uterine cavity, and it's to stop the implantation of a pregnancy occurring. And often they release little localized hormones to help stop a pregnancy occurring. So it shouldn't be in the cervix. It has to be passed through the vagina, through the cervix, and it should be placed up in this uterine cavity area. So on ultrasound, we would see it sitting up in this area. We don't want it sitting down here. It would be highly uncomfortable, because this cervix is often on a angle, as you can see, and the intrauterine device is more of a flat thing. So it has to stay in this flattened out uterine cavity area. Does that make sense?
Yeah, thank you.
They often have the Marinas, they get put in here, and then they have a little string that comes out. So the Marina, the intrauterine device, will sit up here, and then the string stays down in the cervix and into the vagina, so that when it needs to be pulled out, that it just gets tugged, and the intrauterine device just pops out this way. This is the sagittal view. Here you can see this urinary bladder is more distended, and the uterus is sitting up more vertically, because the bladder's pushed it up so that it's not tilting forward. When we talk about this uterus, we have spaces. There's a space between the bladder and the uterus, and there's a space between the uterus and the bowel here, or the rectum, whatever part of the bowel you want to call it. The rectum is part of the bowel, so we can just call that bowel as well. This space here is an important space. This space that sits posterior to the uterus, and in between the uterus and the bowel. It's got lots of names. All these names mean the same thing. So it's in anatomy, and it's often confusing, because someone will call it one thing, someone will call it another thing, and they all mean the same thing. So let's break these names down just so you understand them. There's retrouterine space. So this is the uterus. The space that sits retro or posterior to the uterus can be called the retrouterine space, because it's behind the uterus. There's the rectouterine space, and that's the space between the rectum and the uterus. So you can see why it's got that name. There's another one, which is more a gynecological term, called the posterior cul-de-sac, and it's meaning posterior. It's a little recess that sits in here, and it's posterior to the uterus, because gynecologically everything's relative to the uterus, because gyne means relative to reproductive organs. Well, there's another term which is used in radiology. In radiology, we use a lot of eponyms, Eponyms are names of things which are named after people. So it's called the pouch of Douglas. So someone, Douglas, say Dr. Douglas, identified this potential space and named it after themselves. And whenever it's an eponym, because it's a person's name, it has to have a capital letter. And I'm trying to give you something. Oh, how are you going to remember this? And I couldn't think of a famous Douglas.
Isn't that
I was like
Doogie Howser? Is that Doogie Howser?
Yeah. I was like, what's a famous Douglas? I don't know any Douglases that are famous. So I was trying to give you a Douglas. So pouch of Douglas. I don't know who this Douglas person was, but just you're going to see it used all the time. And so you just need to know that's a pouch of Douglas. I've got no easy ways. So if anyone wants to share a picture of a more famous Douglas, I did look some up and there were YouTubers and I went, I don't know who they are. So I had to throw one in there that people might relate to. So let's have a look and see if we can see this pouch of Douglas or rectouterine or retrouterine space. So here's our uterus. This is anterior and this is posterior. Here we have bowel, so it's going to be sitting immediately posterior to the uterus in here on the image. The reason this space is really important is, say someone has endometriosis or something like that and they've got bleeding that's happening outside their uterus. They end up with free fluid in their pelvis. And we often scan the patient supine or lying on their back. So when they're lying on their back, the fluid gravitates to the most posterior place. And the most posterior recess where the fluid is going to sit is here. And so we see free fluid sitting in this on imaging, on ultrasound particularly, and on MR and on CT. And so it's a common spot that we need to identify. We need to look there, even when it's normal, to say there was no free fluid in the pouch of Douglas or there was free fluid. And then if there is, we would comment on how much was there. Does that make sense? And why it's important? Sort of.
Yes.
So we talked about the space posterior to the uterus. There's also a space anterior to the uterus, and that obviously sits between the bladder and the uterus to a degree. And so we called the bladder, we said things that pertain to that are vesicular. And so we could call it the retrovesicular space, meaning posterior to the vesicle that holds urine, the bladder. Or we could call it the anterior cul-de-sac, meaning it's anterior relative to this uterus here. So that would be sitting in this area here, between the bladder and the uterus. Does that make sense? So this is a picture of the uterus. It's anteverted because the fundus is pointing anteriorly and the fundus is sitting over the top of the urinary bladder because the bladder is not very full. This would not be a uterus that would be easy to see on a transabdominal, meaning we're sending sound through the anterior abdominal wall on a transabdominal ultrasound. We need the bladder to fill up to form an acoustic window like this to allow us to send the sound in and up through to transmit the sound waves through to the uterus, and it allows us to see it nice and clearly. So we would put the probe just superior to the symphysis pubis and send the sound waves up that direction. If we had to put it here, we're just going to see it all folded over on one another. So that makes it difficult. Here the bladder is not very full. I'm not quite sure why there is a whole lot of fluid in this rectum. That's unusual. But you can see the uterus sitting here. Would you call this an anteverted or a retroverted uterus?
Retro.
It's anti. Think anti, fundus to the anterior abdominal wall. Anteverted, the fundus is closer, pointing more to the front. I'll show you some retroverted ones shortly. This is still probably an anteverted uterus. It tips up once this bladder is full. So you can see we've got the symphysis pubis here. This is our anterior abdominal wall muscles. We have our bladder. We have our uterus. What would you describe this area as that I've got my marker on?
Cervix.
The cervix, and then the vagina there, and then the rectum. What space are we looking at here?
Douglas,
Pouch of Douglas.
Pouch of Douglas.
Any of those 4 names, yep, pouch of Douglas, and then more our retrovesicular space or anterior cul-de-sac. So now we have to transfer this sort of an image to an ultrasound image. So we can fan this uterus down, straight, or fan it up, depending on where we've got it sitting relative to the pubic symphysis. In this case, we're probably holding the probe and sending the sound up this direction. We have the urinary bladder, which isn't very full in this case. And then we have the uterus here. So we have the probe on the anterior abdominal wall. So this is anterior. This is towards the head because this is a long axis image. And this is towards the feet, and this is posterior. So this here is going to be the region of our rectum and bowel here. So what's this white or echogenic stripe indicating?
Endometrium.
The endometrium, that's right. What am I outlining here with my marker?
The fundus.
The fundus. So you can see the fundus is pointing more to the head. So we've probably got the uterus sitting in more of an orientation like on this image here. What area am I outlining here?
Cervix.
The cervix. Can you see? We can see the endometrium down to about this point, and we don't really see endometrium down through the cervix. Can you see that on the ultrasound? Because this is closed. The cervical canal is closed, and we see the endometrium lining the uterine cavity up here. And then we have the vagina here. Is everyone feeling okay with that image?
Yeah.
So this is myometrium. Would this be anterior or posterior myometrium?
Anterior.
Yeah, because it's more anterior. It's closer to the anterior part of the body here. And so that makes, what myometrium would this be?
Posterior.
Posterior myometrium. That's really important because when we do an ultrasound, you can get things that sit in the muscly part of the uterus or this superficial lining of the uterus called a fibroid. And we need to say where they're sitting. Are they sitting in the anterior myometrium or the posterior myometrium? So understanding those different components, weirdly, this is the anterior myometrium and the posterior myometrium on this uterus, because when it tips up, this will sit anterior and this will sit posterior. Do you get that? It's a bit abstract. We tend to use anterior and posterior in our ultrasound images. So this is the diagram where we have anterior abdominal wall, bladder, uterus, rectum. We won't really see the sacrum on the ultrasound image, but I've had to spin this diagram all the way around like this to represent this image here. Do you see how we're sort of spinning the way we look at the ultrasound images? If you're sitting there and totally confused, you are totally normal. It takes a bit of a while to digest and work that out. We have the ultrasound probe in a long axis orientation. So this part is pointing towards the head and this part is pointing towards the feet. So this is towards the head and this is towards the feet. And that's the way we hold the ultrasound probe. You would have probably learned, you know, that each probe has, I've probably got one sitting around here somewhere, a notch, and that notch either faces towards the patient's head or towards the patient's right side to allow us to get an image that's orientated in the right way. Yeah, you can think of it. I've never thought of the probe like a knife before, but yes, you could sort of think of it that way, just that always the tip of the knife always has to be pointing to the patient's right side. when you're in transverse. So I've just sort of drawn the diagram here. We've got the symphysis pubis, that will be down here. We're not seeing that on the ultrasound image because we can't see through that. So the probe will always be positioned superior to the level of the symphysis pubis and send the sound in this way. So if you're wondering why you can't see the symphysis pubis on this image, it's because you will get a whole lot of shadowing from it. So here we've got anterior abdominal wall, urinary bladder, uterus, cervix, vagina, and then the region of the bowel. What potential space am I looking at here?
The pouch of Douglas.
The pouch of Douglas. So see how we look to find the uterus and look immediately posterior to it to see if there's any fluid. There's no fluid in here, so we don't really see it. And that's what happens in imaging, that there's all these potential spaces, and when it's normal, those potential spaces have nothing in them and we don't really see them. We will only see them when there's something abnormal or pathological there. It doesn't mean that those spaces don't exist. It just means that they're not filled with anything unusual at that point in time. I think we can label all of the things here. So we've got our anterior abdominal wall, our urinary bladder, our region of our endometrium, because this white stripe is actually showing the actual endometrium. What would this arrow be pointing to here?
The fundus or the body?
Yeah, that's more the body. The fundus, see the endometrium goes to this point. So sort of where I'm outlining with my red dot is the region of the fundus. See how it's superior to the level of the endometrium?
I can see that now.
Yeah. No, that's good. It's good to clarify. So this would be either posterior myometrium of the body of the uterus, I suppose, is our absolute correct answer. This one would be pointing to the region of the cervix. What's this one here pointing to?
The vagina.
The vagina. This one is the region of the pouch of Douglas. And what's this one here pointing to?
The bowel.
Yeah, so with bowel, as I showed you in the CT and the MRs, it often contains air. So what we see is the sound comes and hits the air and reflects back this bright reflection, and then we just see what we call dirty shadowing behind there. So it looks like an abyss of nothing, but we do know that that's the bowel. So these are just some images from a protocol that you will end up scanning when you learn to scan the female pelvis. And this is that image, the long axis view. This is just a zoomed up. You can see it's just focusing in just on this area here of the endometrium. Can you see the little calipers between here and here have measured the thickness of the endometrium? The endometrium would describe as a homogeneous echogenic stripe. It can change in thickness throughout the cycle. So straight after a period, when someone's had a period, it's really thin because they've just shed all of the endometrium. And then over the female cycle, it gets thicker and thicker. And just before someone's about to have a period, it's at its thickest. And then once they start having their period, it becomes thin again because the endometrial tissue is shed out. It comes down through the cervix and out through the vagina that way. This is just a zoomed up picture just of this area here to show this cervix, to show that there's no cysts or masses within this cervix, to show that the sort of canal is generally closed and that it's of a reasonable size and length. Is there a maximum size of the endometrium? Yeah, we have measures of it. It can be up to usually about 14 millimeters thick. And if someone's postmenopausal, meaning they're not having a period anymore, it can be up to about 6 millimeters thick. But we sort of also need to look really closely at it to make sure there's not any focal areas of darkness or decreased echogenicity within it that might indicate some changes. So I think I've got a picture a bit later that shows one a little bit thicker. We tend to do trans-abdominal imaging, so imaging through the anterior abdominal wall, and transvaginal imaging on most patients that will tolerate it, because when we do a transvaginal ultrasound, the transducer sits within the vagina here, and it gets an image just of the uterus, and it gives us a much clearer look at this endometrium and this myometrium, because it uses a higher frequency transducer, which gives us a higher resolution image and a clearer image. And we don't have to deal with any bowel or anything like that. So I've got some images to show you with the transvaginal probe as well. This is just a zoomed up image just showing the vagina, and then the cervix, and then the body of the uterus would be up this area. If this is the vagina and this is the bladder, what is this area here out the back representing?
Rectum.
Yeah, bowel. So can you sort of see the bright margin and then funny shadowing behind it? And that's just air, and combination of air and poo that sits in there. Yeah, it gets a bit weird looking at bowel on ultrasound because you don't overtly see it. You see where it sits. And you'll appreciate that probably a little bit more when you study the physics of ultrasound. This is one of these transvaginal ultrasound images of the uterus. So you can see it's much bigger and much clearer than the transabdominal ultrasound image. So I'll outline the uterus for you. So what I'm outlining here is the uterus. This area here will be the cervix. This will be the body of the uterus, and then the fundus will be just this bit that sits above the region where we can see endometrium. Can you see that? Sort of think of it, I've put this here to outline the area of the uterus that it was showing. We don't see the vagina because the transducer's in the vagina, but the bladder, the urinary bladder, is completely empty. So this tips all the way forward here. So when we've got the probe here, it's like the uterus is like a T, like the transducer's like this, and the uterus tips over the top, and we get to see it. So the uterus is the transducer is in the vagina, which is here. So the vagina comes here, and then the uterus tips over like this. It's a bit of an abstract concept. This is
how
yes.
would you label that? So is it superior, inferior?
So this is towards the head, and this here is towards the yeah. This is more distal, this is more proximal, and this is more distal. These are, think of it, it's hard for you. Yeah, I don't give you too many of these because it's a different way of thinking. You always should see the fundus of the uterus on these, on any images I show you. So, and you should see the endometrium. So it's more, where is the fundus of the uterus and where is the cervix? Because if they're retroverted, it will actually point the other direction. And I'm not including that because it's too much for your brains to comprehend at this point in time. But basically you would see the fundus pointing down this way here. So more on this, just get used to identifying your fundus, identifying your endometrium, and identifying your cervix on this view. I have got the region of the bladder indicated here. If this is where the bladder is, what's going to be out in this area here?
Bowel.
Bowel, because it's going to be on the opposite side of the uterus to the bladder, isn't it? If we go back to, we saw bladder, and so you must know that rectum sits on the other side of the uterus relative to where the uterus sits, because the bladder, if it sits anterior, the rectum's going to sit posterior. Anterior and then rectum posterior. So if we go to this view and I've got region of the bladder outlined, you'll know that the rectum will sit out here. Is that making sense?
I'm a bit confused because this person's got a empty bladder. So the vagina is sort of like.
I'll show you what it's like just to help
flat.
you.
So
It's
I
gonna
would
be
put on
like
the other
this.
side. Yeah.
Think of it like this because the bladder's empty. So when you put the transducer in, the transducer comes up to this point, and see how it would be meeting the uterus like a T?
Oh, so it's more on that angle. I'm thinking that's sort
Yeah,
of
so
like
the
straight up. Okay.
transducer's coming up to here because you
Does
always
it
want to
enter the
empty-
cervix or does it sit
No.
prior to the cervix?
No, it's only into, because we can see the cervix, it's only in the vagina to about here. So you put
It's
it into the
facing
vagina
backwards a bit.
and then you see the uterus perpendicular to where you're holding the probe. So we come back to this image, we're holding the probe here and the uterus is running along at a T junction relative. We're putting the transducer in the vagina here and then like that. And then the uterus is sitting at a T like that. So it's sitting perpendicular to where the transducer is being held.
But I guess, Michelle, the transducer is more sort of like that, right? Because there's like it looked like on the other picture, the vagina is sort of tilted.
Yeah, there's a bit of a tilt.
And
It's
that's
not
why you
perfect.
can see the bowel because it's over here, right?
Yeah, yeah. So you're going to see at the front, so we're holding the transducer tip here. So we could see a bit of bladder right near where we were holding the transducer. Then we see uterus, and then behind it, you're going to see bowel out there.
Okay, so there's bowel there. Okay, yeah,
Yeah.
gotcha. Yeah.
Yeah.
Thank you.
As I said,
Is
it's
the
one of
pouch of
those
Douglas
concepts-
visible in that?
What's that?
Pouch of Douglas, not visible in that one?
Yeah, you will still see fluid that sits out more down in this direction down here, out here, posterior to the cervix region.
Okay, and if we're to describe what we're seeing, are we to add that in or just say bowel?
Oh, the region of the pouch of Douglas and then bowel, yeah. I'll try and give you some, I might even send out an email with a picture that shows some fluid in the pouch of Douglas so you can see where it's actually outlined. That would actually be easier if I included that.
Thank you.
Can you see the endometrium here is like a thin stripe? And this uterus here, you can sort of see a bit of the bladder here in this view on this one. Can you see that dark fluid there? Can you see this endometrium is quite a bit thicker compared to this? So this person would be later in their cycle, closer to having their period and having to shed all of this endometrium. So the endometrium lines this part of the uterus and it comes around and it lines this part of the uterus. So that white line right in the middle of those two layers is indicating the actual cavity, the space between the two layers of the endometrium. Because that cavity is front to back and side to side in a way.
So we don't see that white line further down into it because the endometrial walls are touching, is that right?
You don't see this white line down here because we're seeing it nice and clearly because of physics, because sound is being insulated perpendicular more to this.
So it's
yeah,
hyperechoic because it's tissue, like
it's an interface,
yeah.
that white line. Yeah, it's not actually tissue. There's a tiny, possibly a tiny, yeah, you just see a little interface there, like you're seeing just here. So with sound, you get a reflection where there's a change in density of tissues. So you're probably seeing the tiny, tiny little interface of the space, which can always contain a slight bit of either fluid or sometimes even a little bit of tissue or something in there. But that's just showing you that there's endometrium here on this side, and then it comes around and endometrium down here. There's two layers of the endometrium because the endometrium lines the cavity. Another hard concept to get. If there was a baby in here, you would see these two layers of endometrium separated, and the gestational sac would be situated right where my dot is in the cavity, in between those layers.
So when like say gynecologists are looking for like egg follicles or something like that, what would they appear like in?
Okay, so when we do follicle tracking, they're in your ovaries. So we track them in your ovaries, and I'll show you that. This picture might help. This is what we call a sonohistogram. It's a bit of a long name. Basically, this is a zoomed up picture of this in a different patient. And we actually sometimes inject a bit of fluid through the vagina into the endometrial, into the uterine cavity. We can sometimes call it the endometrial cavity, to outline whether there's any growths or anything that are coming off this endometrium. So here you've got endometrium here, coming around here and coming down here, and it's outlining this endometrial cavity, or this fundal end of the endometrial cavity, because it's closer to this rounded end of the fundus, and just showing that there is actually a cavity in there where this white line is situated. Once again, it's a harder concept to understand. Sort of need to remember that there is a space in here. The two walls are opposed together. We can open it up by injecting some fluid in with a little catheter, not with a needle, with a little catheter, and opening it up. And when a baby develops, it sits in here. So when we do an ultrasound for an early pregnancy, we're looking to see if we can see a little gestational sac that will be developing in the endometrial cavity or the uterine cavity. And sometimes it implants, and it implants on usually one side. So it might implant on this side of the wall or this side of the wall. It doesn't just float in there, because it has to attach to develop blood vessels to, get all of their blood supply and growth from the mother. So it has to actually implant, but it sits in this cavity, it develops in this cavity, but attaches to one side of the endometrium initially. So wasn't the fundus the head? Yes, so the fundus is this, but we have the fundal end of the uterine cavity, if that makes sense. This would be more going down the distal or cervical end of the uterine cavity, because you can have two ends. So this would be the fundal end, and that would be more the cervical or distal end of that cavity. This is a retroverted uterus. So here we have the symphysis pubis, the bladder, and then the vagina, the cervix, and the either endometrium or uterine cavity, and the fundus of the uterus is pointing posteriorly. Remember, anteverted, A is for anterior pointing. Retroverted means it's pointing retro or to the back or posteriorly. And so that's what a retroverted uterus is. And this here on this MR is showing a retroverted uterus because the fundus is pointing towards the bowel and that spine. Can you see that? Let me go back and see if you can compare this diagram to a retroverted uterus diagram. Oh my goodness. Well, this is a retroverted uterus. See how the fundus is pointing in, this is an anteverted uterus. See how the fundus is pointing anteriorly on this MR? And then when I go back to this MR down here, sorry, the fundus is pointing to the spine. So they're the two different tilts that you get of the uterus. Both are completely normal. It's just a variation in the way that the fundus of the uterus tips and points.
So does that uterus, when you've got a baby in there, does it end up taking up the whole cavity space regardless of whether it's retro or antro?
Yeah, it doesn't really matter. The whole uterus will go woo, all the way up, like to your abdominal organs. So no, it doesn't matter which way it's tipping. It doesn't seem to affect fertility or anything. It just, and that's what I was saying, though the uterus and the ovaries are mobile because they have to be, because when it's pregnant, everything moves and gets squished out of the way. some people can have an anteverted uterus and sometimes it can tip retroverted. I mean, we see all sorts of things with ultrasound, and you start to think, am I going mad? I'm sure it was anteverted, and now they go to the toilet and then it tipped retroverted. You go, oh, I've got no idea. So they do all sorts of weird things, these uteruses. They're an interesting thing to image. So this is the retroverted uterus here. And when we do an ultrasound, it's sort of the fundus here is tipping back towards the spine. Can you see that? Instead of it's sitting more up, coming up this direction that we used to see, the fundus, we say this is anterior and this is posterior. Can you see the fundus down here is pointing posteriorly, more to where the spine and the bowel is sitting? So you can see anterior abdominal wall, urinary bladder, and the fundus is pointing to the bowel and the sacrum, as it's doing in this image here. Does that make sense? Hopefully. If it's not, it is sitting there, and you will, one of those things, you're going to have it and then you're going to get confused because it's flipping your knowledge of this into a totally different orientation. So this is towards the head and this is towards the feet, and this is anterior and this is posterior on this patient. Anterior and posterior towards the head and towards the feet, as opposed to anterior, posterior, superior towards the head and towards the feet on this MR image.
So it's a longitudinal view.
This is a long axis image, yeah. So when the bladder is completely empty, when we do an ultrasound image, we often get this sort of appearance. I mean, often we don't see too much, but this is just showing you, this is anterior and this is posterior. We will have the vagina coming up through here, the cervix, and then it nearly looks like this points down back towards the feet in a way, because it comes and points down there. The fundus is pointing anterior-inferiorly, like, yeah. They sit all over the place. This is not optimal viewing for ultrasound. We can't get a good look at this endometrium. We're not getting a good look at this myometrium. On this patient, we would either have to fill their urinary bladder, so get them to sit out in the waiting room and drink a whole lot of water, or we would have to go straight to an internal ultrasound where we need their bladder emptied to get a much better look at their uterus and endometrium. We're also not going to get a good look at the ovaries with the bladder like this empty.
Is there a difference between the two, transabdominal and transvaginal, as to what we see and why they don't just do the transvaginal first?
Well, not everyone wants to have a transvaginal. Transabdominally, we get a much bigger field of view. So we use a low frequency transducer. We get it's like you get a field of view this big, and when you do the transvaginal, you get a field of view this big. So sometimes things can be further away from the vagina and they're too superior. I mean, you can only poke that transvaginal probe up so far. So if things are more up towards, the diaphragm region, more towards your chest, and you can have really big, cysts and things, you won't see it all on a transvaginal ultrasound. So your transabdominal is like an overview map of what's going on, and then your transvaginal is a zoomed in, you're looking at a map and then you zoom right in and you blow that up and look at a particular area, if that analogy
Is it
works.
more so like you can, when you do it transabdominally, that you can like measure the bladder and stuff like that?
Yeah, if we need to look at the bladder, yeah, we definitely need to do a transabdominal ultrasound, because we won't see it on a transvaginal ultrasound. It's just more it gives you an overview, because sometimes there can be big obvious things that can sit outside the field of view with your transvaginal ultrasound. So your transabdominal ultrasound is done with like a 3 megahertz frequency. So it means you've got a lot more depth penetration and you can see a lot further and deeper. When we do a transvaginal, the frequency is like about 13 megahertz. And so it gives a much more high resolution image, but we won't get that depth of imaging. So the field of view is limited.
It's amazing how many women I've spoken to who would prefer the transvaginal because it's not as uncomfortable as the bladder.
Yeah, having a full
and they've
bladder
all said that to me. They're like, why don't they just do that one instead of making me drink so much?
it does give you an overall map of what's happening. And yeah, there can just be some things that you may just not visualize on that transvaginal. It depends where different departments will have different protocols as to what they work through.
That's good, because now I'll be able to give them the map
Yeah.
scenario and explain it to them that way and say, that's why.
And it's the same with breast imaging as well. Like the mammogram gives a road map of the whole boob, and then ultrasound, we focus on little areas as well. So yeah, it's a similar sort of thing. This is a coronal view, and the reason I'm putting this in here is when we do the ultrasound, we can sort of tilt the probe relative to when we're doing transverse and even longitudinal views, and they're not completely axial. They tend to be part axial, part coronal views. So it's good also to know where things sit in this coronal sort of plane of the body. If we did a coronal slice, like a slice through the body this way on MR, if the bladder is empty and you could see the uterus would be anteverted and the fundus of the uterus would be pointing towards the anterior abdominal wall, we get a cross-sectional view through the uterus. So this is like a short axis or cross-sectional view. This is the right side of the body and the left side of the body. We can see myometrium and the endometrium in through here. And you can see that the uterus is sitting superior to the urinary bladder, which is quite empty on this patient, because this is towards the head and this is towards the feet. They're the femoral heads that you can see just out there to the side. So you can see the femoral head here and the femoral head here, the uterus, fallopian tubes, and sort of ovaries. We won't really see the fallopian tubes. We can sort of start to see where the ovaries are sitting in here, and I'll get to them shortly. So this is sort of the plane that this coronal is taken through. See how when the bladder, the uterus tips forward and we're getting a cross-sectional view through it that way? And so we're seeing it like this. A little bit abstract, but we'll unpack this. So this coronal view often looks like what we're going to get on an ultrasound of a cross-sectional view of the uterus. So this is the uterus here, and this is an endometrium, which is thicker. This is someone that's just about to have, a period, like they're late in their cycle. And so can you see that this correlates with this sort of an image here? This is a short axis view. This is a transvaginal view. This is a transabdominal view of the uterus, and it sort of looks the same as this transvaginal short axis view. We tend to call it trans, but it's really, when we do it transvaginally, it's really a coronal view of the uterus, but we call it a transverse, meaning short axis view of the uterus. So you can see the endometrium here, and you can see like a little area of the endometrial or uterine cavity is that little dark line in the middle between the two opposing layers of the endometrium. Can everyone see that? So when we do the axial view, we angle down and then we angle straight and we angle up this direction. So you don't just do a view at one, you do what we call a fan all the way through. This is just an MR where the uterus is tipped forward and it's an axial MRI, but we're only sort of seeing this myometrium of the uterus here. It's a bit of an abstract view. On this view, we get a really good look at the ovary, or one of the ovaries. Which ovary is that going to be here?
That's
the left.
The left, yeah, because our right one will sit here on this side of if this is the uterus, the right one will sit out here. and the left one will sit out here. So there's little bright dots, which are the follicles, which is labelled here. When someone asked about the follicle tracking, we will get to that when we talk about the ovaries, because the follicles sit in the ovaries. And then we often track to see which is the largest follicle. See how they're all different sizes? So when follicles get to a certain size, and when the largest one is usually the one that will pop and ovulate and send out an egg. And we'll do the pathway of the egg shortly. We've sort of looked at the transverse view of the bladder in the male and said, oh, the bladder nearly had the kitty cat shape. It can be square, it can have the little ear appearances, it can be quite round. When we do a transverse view, this is going to be anterior, this is going to be the right side of the screen and the left side of the screen. This is probably more the cervix or nearly down to the vagina when it's labelled uterus here. And then we're going to have the rectum out more posteriorly. So from anterior to posterior, we're going to see bladder and then sort of the uterus region and then the rectum. Is that making sense? The same as what we saw on those CTs, think of nearly of the pelvis and MRs of the pelvis when we looked at the axial view. So here we've got the bladder and we've got the transverse or the short axis view of the uterus, which is sitting posterior to the full urinary bladder. What I was saying is we sort of we angle the probe up here and we can then fan it in all different directions down more towards the feet, and we can take a series of short axis views from the superior part of the uterus down through the body of the uterus, down through the cervix and down through the vagina. And when we do that, we will get this image, which is probably up at about this level. We can see a bit of endometrium. It's up towards the fundus region. You know, it's up high in the uterus. And then we can take a few different images down through the body of the uterus where we can see the endometrium. It's not very clear in these pictures down here. And then we'll take an image down at the cervix level here. Oops, sorry. And then we're going to take an image angling all the way down towards the vagina, which is this thing here with this little stripe in it. So we've got the urinary bladder, the vagina and the stripe. And what do you think that thing is out the back there?
Synthesis.
What was that?
Synthesis.
This will be probably rectum, depending
okay.
on how much you've got it angled. It could even be like the anal area. Yeah. So can you see that this is taking images from a superior, middle, and sort of inferior level as we've scanned through? So that's why you've got to think that we do a fan, because we have to scan through the urinary bladder and use that as an acoustic window. If we put the probe up here and just dragged it down here, there's no bladder up here. So we would have no urinary bladder to use as a window. So we have to put the probe at the same point, fan the angle of it so it's pointing up, and then so the region of the transducer stays in the same. We just tilt it from down here to up here, if that makes sense.
So it sits just above the pubic symphysis.
Yep.
But if you went any further, you'd get reflection and it'd be pointless, wouldn't it? You'd hit the bone.
Sorry, what was that?
If you went any further, you'd hit the bone, so you wouldn't be able to see the structures behind
No,
it.
you can't go any further lower because you won't see through the bone, and you can't go any further higher because there's just going to be bowel there and we can't see through the bowel. So you really have a very small window where you can place that probe. It's basically, if someone has pubic hair, it's like literally above the pubic hair line or where the top part of that would sit. If anyone has a Caesar scar, it's basically right over a Caesar. A cesarean scar line is where you put the transducer. So to make it a bit easier, I'm like, okay, you can find the bladder, that's okay. And then we talked about it having a kitty cat head. Imagine the cat was really hungry and wanted to eat a donut. And that's the uterus in short axis really does look a bit like a donut. So just think it's a really hungry cat and then it's going to eat a donut. I don't know if that helps, but
I think it sort of looks like a man in a ski mask, like with a
Oh,
little
okay.
mouth and then, yeah. Pursed
Yeah.
lips.
Oh, yeah. I think I see that. Like ski goggles, do you mean?
Yeah, sorry, yeah, ski goggles.
Could be
Yeah,
like
yeah,
a motorbike
yeah,
helmet too.
Yeah.
So this is a really full bladder. So it's a massive cat head, but there's a very small donut down here. So that's the uterus, that's the endometrium. And then on either side of that uterus, you can imagine the cat has its paws there, and they can represent the right and the left ovaries. Because the ovaries sit either side, well, I haven't got the donut there, but they will sit on either side of the donut usually. And so the ovaries, they've got a particular pattern. So they've got all these little black dots or anechoic dot areas on ultrasound. So they're fluid filled. Think urine is fluid and black is fluid. So these are fluid filled. They're tiny, like little cystic sort of areas. And they're all the follicles in the ovary. Because basically on the ovary, we have solid tissue, which we call a stroma, and then follicles. Once someone's not ovulating, say they've gone through menopause, so they're post-menopausal, we shouldn't see too many follicles in their ovaries because they're not producing any eggs anymore. So their ovary would look a little bit more less, you wouldn't see the dark spots in those, if that makes sense. Can we see the fallopian tubes here? I can't see them. We're not expected to see them on ultrasound. If we're seeing the fallopian tubes, something is wrong. So we should not see the fallopian tubes when they are normal. Can we see the ureters? They're the tubes that connect your kidneys to your bladder. Can we see those on ultrasound? Should we see
Maybe
them?
with the Doppler?
No, we saw the ureteric jets. We saw the urine that entered the bladder from the ureters, but we won't see the ureters, and we won't even really see them on CT. Maybe we can see a tiny dot where they sit on CT, but no. And it's the same in the male. We won't see that ductus deferens either. So lots of those small little tubes we won't see on imaging. So we can't see the fallopian tubes here. We can't see the ureters here. When they're normal, they should be just collapsed and not contain pus or fluid or anything like that.
So if
would
there's
ectopic pregnancy show the fallopian tubes?
An ectopic pregnancy can sit in the fallopian tubes. Ectopic, for people that don't know what that means, ectopic means something is sitting where it shouldn't, in an abnormal position. So an ectopic pregnancy is a pregnancy that's not sitting where it should. We said that it should sit in the uterine cavity and embed where that endometrium is. So if the pregnancy is not sitting there and sitting somewhere else, that's called ectopic. The most common spot for it to sit is in the fallopian tube, but it can sit in the cervical canal and it shouldn't sit there. So that's an ectopic pregnancy. It can develop out in the abdominal cavity, say like out here, and that's not normal. And it can even develop in the ovary, very rarely. And sometimes it can develop in the junction between the uterus and the fallopian tube, which we call the cornua, and it's not supposed to develop there, so that's ectopic. So yes, ectopic pregnancies, we can see them in the fallopian tube, so that means we're seeing a fallopian tube, which means it's abnormal on ultrasound. Oh, there's that I would look a lot happier if I'd taken a bite of that donut, but that cat still does not look happy, but I think my ratio of the cat head and the donut is a bit out of whack in this picture, but you can sort of get the view and you can see the little paws are sitting on either side of the donut. So just so it helps you think of where things sit, visuals are really helpful, so use them. And this is just one of those MRI master things. You can sort of see the uterus here, see the endometrium here. You can sort of see bowel here. That's probably all I would be expecting you to pick out on you know, in terms of reproductive organs on that view. We're not really, the ovaries are not really obvious. When we're looking for ovaries, we want to see spotty sort of things. Now, I've got this image in here because I've said several times that the ovaries, although they should sit here, are very mobile, and on some people, and quite a lot of people actually, they sit in all different positions. So sometimes they sit well above and on top of the uterus. So think of it like a cat in this position. Sometimes they sit down really low and one sits up high. Sometimes they sit posterior to the uterus, behind it. So those ovaries are very variable in their position because they have to be to allow the position to change when there's a baby developing in that uterus. I've got some pictures of the ovaries here. So this is a transvaginal ultrasound image of an ovary, so that you can see that the probe is right up against where one of the ovaries is sitting. It's got the little black dots, which are the follicles. So the follicle is like a little round area which contains fluid, and a tiny egg develops in there. The reason it has a bit of fluid is it has to, at some point, expel the egg out of the ovary. So say this was a follicle here and there was an egg in here, it would pop the egg out, and then these fimbriae, these finger-like projections from the fallopian tube, capture the egg. So the little egg's here, it goes, poof, captures it, and then it has to transport the egg down through the fallopian tube, all the way through at this junction between the uterus and the fallopian tube called the cornua, into the uterine cavity. It may or may not become fertilized when it's sitting there. If it's not fertilized, it just pops out and is shed through with the endometrium shedding at a time of a period. If it is sitting in here and it gets fertilized, it should develop in here. As I said, sometimes sperm can hit it and fertilize it here or out here, or even potentially as it's exiting the ovary here, or sometimes the egg can get fertilized as it's exiting through the cervix, or sometimes it can even sit just in this cornua. And these are all the spots of where an ectopic pregnancy, a pregnancy that's not sitting in its correct position, can sit. Does that make sense?
Sorry, Michelle, so they're actually not connected, the ovary and the fimbriae?
No, there's a space. I think there's some tiny little things that help to potentially hold it, but there is a space where the egg pops out into the abdominal cavity and then has to get into the fallopian tube.
Yeah.
So for a moment in time, that egg sits in the abdominal cavity.
Can it stay there? And what happens if it does?
So it potentially could stay there. If it does and it doesn't get fertilized, it's like you know, a
Does
cell.
the body eat it up again, or does it just
Yeah,
stay
it's just
sitting
a cell
in there
and
forever?
it just sits there and nothing happens to it. If it potentially got fertilized at that point, very, very unlikely, but can happen, the baby can develop in the abdominal cavity, but not within the uterus, not within the fallopian tube. And it can actually develop to be quite a size because it's not restricted by any space. If it develops, if the egg gets fertilized here in the fallopian tube, it's quite a tight space and it can only develop, and it's quite vascular. And so it's not going to be compatible with life. It causes a lot of pain for the mother, and the fallopian tube and the developing gestational sac have to get removed. So when someone's had an ectopic pregnancy on one side, you ovulate from your ovaries. You've got two ovaries. You've got one on the right and one on the left. 1 month, you will ovulate from, well, females, not males, ovulate from one ovary. The next month, you ovulate from the other side, on the other ovary. And it swaps. So if you take away one of these fallopian tubes, this you will still ovulate. So this will just sit in your abdominal cavity and nothing will happen to it because this gets tied off. But you will only fall pregnant every second month, depending on what that is, because you will only have the follicle moving from the ovary to a fallopian tube on one side.
Will we see the eggs, if that's the case, sitting in the space there during ultrasound?
We don't even see an egg on ultrasound. We see these follicles. The egg is like a single cell. We don't see it.
Okay, so it's not something we'd expect to see unless it
So why
had
don't they do a
migrated.
nephrectomy anyway?
What's that?
Why don't they do a nephrectomy when they take the fallopian tube out anyway? If it's just going to sit there dormant, why don't they just take it out?
So for people that don't understand, rectoectomy means removal of. Oof is what we often refer to as the ovary. So we can have a oophorectomy, which is the removal of the ovary. We don't want to take out an ovary prematurely because the ovaries produce hormones.
Oh yeah, okay.
So you will take out the fallopian tube. They're just a channel for the conduction of the egg. But these ovaries, they're hormone producing and they're quite important, and you want those hormones maintained.
Yeah, menopause sucks.
So, but that's a good question. So yeah, so they take out the fallopian tube. If the ectopic pregnancy develops in this cornua here, it's a very vascularized area. That's like a medical emergency, and if it's not picked up, the mother can die from bleeding with an ectopic pregnancy there, even before it's diagnosed, and the same in the cervix as well. They're very tight, compressed places. And so as this gestational sac, we call it, and developing fetus expands, because they grow, they impact the tissue around it and they can cause a lot of bleeding. And so that's why an ectopic pregnancy and the diagnosis of it with ultrasound is a really urgent examination. You can sort of see the ovaries here. This is an older MR, but it sort of showed it. And can you see all of those rounded follicles are all different sizes? So there's follicles that are developing at all different stages of development, because they sit there, they build up, and then they pop out once a month from one side, they pop out from the ovary at the other month. But they're constantly developing there when someone is of a hormonal age for that to occur. So here you've got the uterus and you've got an ovary and an ovary here. Which ovary do you think this one might be? This is the ovary, this is the uterus, and this is the ovary. So this ovary is corresponding to this
right
ovary here, the right. That's right, because it's on the right side, and this is the left side of the patient because it's a transverse. You probably can't see that. I cannot get rid of that B&O. It's on a transverse view. I've just got to watch the time because I'll have to leave at about 1:45. So I've drawn follicles here of different sizes. This fallopian tube, you can call it uterine tube. You'll see them called oviducts. Once again, it's confusing because there's multiple different names. They have different parts of them because we may sometimes say, you know, like they may want to know what part of the fallopian tube some pathology or something wrong may be in. So finger-like projections are called the fimbriae, however you want to say them. Maybe say fimbriae so you know how to spell them correctly. And then there's an infundibulum. Then there's an ampulla. An ampulla is usually like a widened connection. We will see the term ampulla in a couple of different areas of the body, the same as we will see the isthmus in a couple of different areas of the body. and then the interstitial portion. This is the portion of the fallopian tube straight after it's connected to the uterus in a way. So there's 4 different sort of areas or parts of that fallopian tube. As I said, we only see these if there's something wrong in the fallopian tube. You won't see it in a normal imaging. There is a little ligament that attaches the ovary to the uterus, and that's just called the ovarian ligament. It's just to make sure that it sort of stays connected, it doesn't wander too far away, and that it stays in relative close proximity to these fimbriae, so that when the egg comes out, it can get collected and be taken through. So it's going to come out here, come out through, and sit in here. So this area here we call the cornua. It's really a part of the uterus, and if a gestational sac was to sit in here in the cervical canal, that's an ectopic pregnancy. It shouldn't be sitting in there. Very vascular, and it's very dangerous. Any questions so far? I've heard fallopian tubes as an outdated term. You can use uterine tubes. You're going to find in different disciplines of medicine, different like surgical discipline to the radiology discipline to obstetric discipline, can call them different names. Yeah, I'm just giving you all of them. It's going to depend in what sort of a department and specialty you work in as to
So basically you need to know all of them because it might come through as that on the referral.
Yeah, you're going to see all of the names. So all of the names are correct. Some terms are outdated, but you could be dealing with very outdated medical people, maybe like myself. So you have to know the current terms and the old terms. When there's usually a consensus paper that's written internationally, so we're moving out of that terminology. But as far as I know, fallopian tube is still used by quite a few people, so you can't completely ignore it. That's just from Draw It to Know It. See, these Draw It to Know It's have lots of different explanations. You might find them handy. This is showing the area of implantation, which is in the uterine cavity. This is showing fertilization occurring here. Fertilization can occur in the uterine tube, but it needs to implant. Like it can be fertilized here, but it needs to travel and implant into the uterine cavity. It can't stay and implant here. That's when it becomes the ectopic pregnancy. This is a picture on ultrasound of a fallopian tube that is filled with fluid. It could be blood, it could be pus. If it's just fluid, we call it hydrosalpinx. Salpinx refers to your fallopian or your uterine tube. If it was pus, we would say pyosalpinx. Pyo is the word that refers to pus. But generally, we won't see this. This is a transvaginal ultrasound that's demonstrated it. And sometimes we can do this with that with the sonohystogram and try and flush it out as well. But we would not normally see this. So you're not going to be able to point it out on an ultrasound. Everything I should give you should be showing normal anatomy. So you shouldn't be pointing this out on a normal ultrasound image. These are ultrasound images showing, this is a gestational sac. We call it a fertilized egg that's developing with a baby in it, and it's developed, this is the sac, it's developed within the fallopian tube on the left. It's right next to the left ovary. It's not within the uterus, and this is an ectopic pregnancy. So this patient, unfortunately, has to have this removed and has to have this fallopian tube removed surgically to allow the mother to stay alive. Very occasionally, we can have a intrauterine pregnancy, which is the normal term, what we want, an intrauterine gestation is what we refer to as being pregnant. And so we can see like a little, what we call yolk sac and a little fetal pole, and the little gestational sac is this black area with amniotic fluid in it. And it's within the uterine cavity here of the uterus. There's also concurrently a pregnancy that has developed in the fallopian tube. So there's an ectopic pregnancy that's concurrently occurring with an intrauterine gestation, and we call this a heterotopic pregnancy, meaning this one's not able to stay there, but this one is. So this person has to have this fallopian tube removed, but hopefully this baby unfortunately will not be able to be maintained, but this one should be able to. They're not the nicest ultrasound to perform because it's usually quite upsetting for everyone involved, but they are really important that we understand the anatomy of the fallopian tube, identifying where this ectopic pregnancy is located, giving an estimated location of it, and then the age to guide the surgical procedures that need to occur following this. So on this
Michelle, has one of these
Yeah.
sorry, has one of these pregnancies happened 1 month, and then the next one has happened the following month as the ectopic?
sometimes someone can ovulate 2 eggs in the same month
Okay.
as well.
Okay.
So this patient has one that's happened here and one that's happened and implanted here. And this one I've drawn a cross through because that one's unfortunately got to go.
Okay.
And another question on that, is there any way that you can actually remove the ectopic egg from the fallopian tubes without having to remove the tube?
No, because they implant into the tube.
Yeah, okay.
Yeah, unfortunately. I mean, that's something that may happen down the track at this stage, as far as I know. And gynecology is not my area of specialty, I must say. So I hope I'm telling, I'm pretty sure I'm telling you all the correct things, but yeah, as far as I know, I'm not as up to date on as much literature as that as I am in other areas of radiology.
That's okay. Thank you.
Let's see the time. Okay, there's ligaments of the pelvis. You won't tend to see these. You probably can see this broad ligament and you can see the region of these ligaments. Sometimes you can see them, but you're not at this stage expected to see them and point them out. But you will be expected to know them for when you go on and do obstetric and gynecological units. So I have to point them out here at this point in time. The broad ligament, as its name suggests, it's broad. So there's broad, round, ovarian and suspensory, and the cardinal ligament's really just the part of the broad ligament that's closer down to the floor, the perineal region. Think of your fallopian tubes like a clothesline. And then if you folded a sheet and hung it over the clothesline, that's going to be your broad ligament. So all sitting through here in this sort of diagram that we had of your uterus and your fallopian tube and your ovary is the broad ligament. Sorry, but the ligaments not connect bones to bones. So I did put this in here and I'm meaning to tell you, no, not all ligaments connect bone to bone. Ligaments can connect bone to soft tissue. They can also connect soft tissue structures to soft tissue structures. So in the pelvis, they will connect soft tissue areas to other soft tissue areas. So in the pelvis, we're going to have a whole lot of soft tissue structures. So it's going, this broad ligament is going to, it's a sheet of tissue, like this sheet. It's going to flip over this fallopian tube and then sort of envelop where the ovary sits. And that's to make sure that this ovary doesn't move too far away from these fimbriae, and it sort of allows a little pathway for the egg to travel along to go into this fallopian tube, if that makes sense. Obviously, the little egg can come out through the little bits of the 2 layers, and that's potentially when it can come and sit out in the abdominal cavity. But just basically think of your broad ligament as a big white sheet that sits on either side of your uterus, and it hooks over a clothesline, and that clothesline is going to be your fallopian tube. And that's probably as simple as I want you to think of it. Otherwise, you get totally confused. And imagine your cardinal ligament is just this inferior end where the two ends of the sheet are sitting off the opposite end of where the clothesline sits. Does that sort of work as an analogy? It sort of extends from the uterus out to those lateral pelvic walls. So here you've got your uterus in the middle, you've got your fallopian tube, your fimbriae and your ovary. This is sort of supposed to be, I just drew this morning, someone's like legs, right and left legs, and their pelvis here. And so your broad ligament would sit over and out through this whole area out here, a big flat sheet. The round ligament, it sort of is a ligament that attaches from this underarm part. Like think of your uterus and fallopian tube like being the body and an arm, and it would come out through your underarm, and then it travels down as a rope, and it comes through your inguinal canal, which is sort of like just above your groin crease through here, and it comes out to the labia area here. You won't really have to look at it. It travels sort of through this area. The reason it's important is sometimes, you know, in the males, how we talked about how their testes developed up in their body, and then their testes travelled down through the inguinal canal and ended up descending and sitting down in their scrotum like this. And there was a structure called the gubernaculum, or a bit of tissue, which was related to that tunica vaginalis sort of area. And it's like a little conveyor belt that allows the path of the testes to travel through. Similarly, these can all be very closely connected when you're a developing fetus. And sometimes in newborn babies, this ovary can come along the path of the round ligament, and it can occasionally sit out in the labial region, because this ovary follows this sort of conveyor belt region of it's very, very rare, but you just need to know the path of where the round ligament sits, because it can be related to some pathologies. You're not going to see it on medical images. We're not going to point it out, but I'm just explaining it to you. It's just a concept. You're going to see it all in the anatomy books and think, oh gosh, that was some of those weird things that Michelle talked about. You're not going to come across them a lot. But remember that the male and females do have similar structures, and the round ligament, you're going to have one in the male and you're going to have one in the female. So you're going to get a little bit confused when you read about it. It just sort of helps to hold the uterus in position, this round ligament, and it gets a bit more stretched in some of those people that have retroverted uteruses, sorry. Switching the time. The suspensory ligament, it's just going to suspend this ovary to the outside, like more to your hip direction sort of thing. The suspensory ligament allows your vessels to pass through. So it's like a tube of a ligament. It sort of nearly forms like a hollow tube, think of it in a way. And within that suspensory ligament, your ovarian arteries and your ovarian veins are going to travel through this. Your ovarian arteries are gonadal arteries, and they're akin or similar to the testicular arteries in the male. So remember, arteries take blood away from the heart and they take the blood to the organ. So your ovarian arteries are taking your blood down to the ovaries. Just distally travels through this suspensory ligament. Likewise, your ovarian veins are going to take blood away from your ovaries. Your right ovarian vein is going to take blood to your IVC. They're going to take, the veins take blood to the heart. Yep, that way. Where does your left ovarian vein take your blood to? Can anyone remember where your left testicular vein took your blood to?
To the gonad, vein, or I can't remember what it's quite called.
Yeah. So it's the gonadal vein. So it'll be the ovarian vein in the female and the testicular vein in the male. And it drained, I think I've got a picture, your gonadal vein on the right drained to your IVC, but your gonadal vein on the left drained into the vein that drains your kidney called your renal vein, your left renal vein. Renal relates to your kidneys, yes. So in the left side on the male, when we looked at those testes, we said that they could get that bag of worms of veins that developed on the left. Remember we talked about that, a left side of varicocele? The same thing happens with females, is they can get a whole lot of varicose veins that sit around their left side of their pelvis. And it can become quite uncomfortable around ovulation time and around the period time. So some females will get like a dragging pain, either at ovulation or a dragging pain around their period, and it just feels like their pelvis is really heavy. They just describe it as this dragging pain, and it's because these veins get a little more dilated, and it just causes pain and discomfort. And so it's more prominent on the left than the right because of the way this vein drains differently on the left. Any questions about that? Oh, I just put a girl up here with left and right just to show you this is the left side that we're looking at. I'm sorry, this is the right side we're looking at here, and the left. It's the same as if someone's facing back, facing towards us. This is their right side of their body and this is their left side of their body. You're going to see the same on these anatomy diagrams as well. So I've just put some in there just so that you can see. Is there any confusion or questions about that? No? I know it's a lot of information. We'll wrap up, I think, with the cervix. I think we've covered the cervix. Imagine this was your uterus. Your cervix is just that inferior portion of it. We have our uterine cavity up here, and then we have a cervical canal. This cervical canal just has a internal os and then what we call external os. I don't know why it's called os. Think of the Wizard of Oz. It's like wizardry. I'm not quite sure. I should have looked it up. I can't think, but it's called the os. Like it's got an internal os, meaning it's closer to the uterus, and an external os is closest to your vagina. Someone was asking about what it looks like. This is a uterus. It's like this, but it's got a baby in there. So the baby is in the uterine cavity. So this is all widened. It's holding the baby, and then you can see the cervix is staying closed to maintain the baby up in the uterine cavity. We don't want this opening prematurely, otherwise the baby's going to pop through this and then pop out the vagina. We want this to stay closed for as long as possible for this baby to develop as much as possible before being born. Is the bladder dark because there's no tissue, mainly fluid? Yeah, the bladder is dark because if we think of physics, the bladder is all of the same material. It's all urine or wee. And so there's no change in density throughout that. And so there's no reflections that's going to occur at a change in density. And so it transmits the sound nicely, because the more reflections you have, the less energy you have for the sound to go through deeper into the body. So we use this as an acoustic window to allow this area to be nice and seen clearly. So it's black because it's fluid and that there's no reflections occurring in there. Oh, os is mouth in Latin. Nice. Okay, there's an internal mouth and an external mouth if you want to think of it that way. Here you can see we do.
It is like it's not necessarily mouth. It's like an opening, I think, an opening or mouth.
Right, yeah, opening mouth makes more sense. So it's an opening. This is the internal opening, and the external opening. Like think of it as the baby has to travel from the internal part of the uterus out to the external part, and sort of think of your cervix as a pathway of a baby. That might be a good way to think of it. We do a measurement on it to show that it's long and it's closed, and see how I've got the cervical length here. And then this is just a transvaginal image, and we've measured the cervical length there. Who wants to have a guess at what part of the baby that is showing there? It's
Fine.
round. What was that?
Fine.
It's round.
I'd say that's the bottom, and then that's part of the lower, the lumbar spine, that sort of thing.
Yeah, it's fine.
What's round in your body?
Our head.
Our head.
Ah,
And remember, we want the baby's head usually to be the first thing that comes out. Otherwise, they're breech if the head's up the other way. So you want the head to be presenting, and then it pushes, for women, it opens this very tight canal, very painful, and it makes the way through this way. So that's the skull of the baby, and you can sort of
it's a
see
third
the
trimester
right
scan.
What's that?
It's a third trimester scan.
Yes, this is late. This patient's 21 weeks. This is
Okay.
mid-trimester scan. So you've got you break the pregnancy or gestation into 3 trimesters. Think like at uni, we have 3 trimesters. And so this is just a 21, we talk in terms of weeks. So the normal gestation is about 40 weeks. So this is halfway through, and it's being maintained. And we do check it with every, pregnancy to make sure that it's staying in there. So here, you can sort of see the baby's head there. These are the 2 hemispheres of the brain, and you can see the cervix, you can see the vagina, you can see the bladder here, and this cervix is long. It has a bit of a bright stuff in it. We call that the mucus plug because it's plugging it shut, and we want it to stay shut. I think we've covered most of this. These are just all the different positions where ectopic pregnancies can be located. As I said, the abdominal one's quite rare. The cervical one is quite rare. This interstitial or cornual is quite rare. The ovarian one is quite rare. Sometimes they can even happen in an implant into a cesarean section scar. So when someone has a cesarean, they don't do a vaginal delivery. The baby's pulled out through this lower uterine segment, we call it. Sometimes a fertilized egg may implant there, but the most proper common ones, 95%, are tubal or in the fallopian tube or uterine tube. I think we're okay with the vagina. We do see like a little stripy sort of appearance. So this is what I was talking about with the transvaginal probe, where the tip of it was located, and why we often see on the transvaginal image the uterus perpendicular to the direction of the transducer. Does that image sort of help there? You might need to go back and look at those in your notes. You'll have it, then you won't have it. It's a really abstract idea, this transvaginal ultrasound, but you can see we've got the uterus, we've got the fundus, we've got the endometrium, we've got the cervix. The region of the bladder would be out here and bowel would be out here. This is the vagina. We often say it's the vaginal stripe. And so when we're looking in a transverse view, it's very flat and shut and compressed down like that. You'll see it look like that on the MR and the CT images as well. I'll give you this. I'm probably going to have to get running to my doctor's appointment. Here you can see the vesico-uterine pouch. So it's the pouch between the vesicle that holds the urine, the bladder, and the uterus. So vesico-uterine pouch. And here they've called it the, you could call it the recto-uterine pouch. It's between the rectum and the uterus. You can call it the pouch of Douglas. You can call it the retro-uterine pouch. You'll see that we covered this. We call this the retropubic space, is the space between the bladder and the pubic symphysis. It's a little we're calling that retro because it's posterior to this. So just you can see these spaces will make a little bit more sense once we've covered the peritoneum, because this is a fold of the peritoneum and little pouches of the peritoneal cavity, which are actually in the abdomen area. I probably won't go through these ligaments today. I'm going to run out of space and time. When we develop, we have little fetal components that exist, and then once we're born, things close off. So we have some embryological remnants, we call them. They're structures that were little vessels usually when we were a fetus, and once we're born, those vessels close off. Sometimes they can make little pathways for things, or they don't close off completely, and they give us little passageways for things. We have one called the urachus. It's where a area was a embryological area sat in our body. Sometimes it doesn't close off completely, so some people can have a passageway from their bladder to their belly button. So sometimes they don't wee out of their belly button, but they can have leakage of wee outside their belly button. And I have seen that on multiple occasions. And so they have what we call a patent urachus, meaning the connection between the bladder, the urinary bladder, and their belly button is patent, means it's still open. So if it's still open, we can go from their bladder, it can go out of their urethra, but it can also leak out this way. Not a highly desirable thing to have, because you can't control that. So they often may need surgery to close this off. Sometimes you can have little cystic areas that sit in there as well. I won't go into that too much, but there are some little ligaments that sit in there that are closed off remnants. That's a remnant of the median umbilical ligament, and we have other ones. We might come across that again once we get to the abdomen, and I'll explain that more then. I won't go over the anal. We've covered the pudendal nerve. I'll let you look over this, and I'll cover this when we get to the abdomen, just to save some time. So don't worry about that for your this week. We will cover some of these a little bit later. If we haven't covered them, then you can forget about them. Are bladder scans in men and women used when there are issues with voiding? So voiding is peeing, yes. We don't really look at the urethra as such. There is an X-ray examination called a micturating cystourethrogram. That means micturating means peeing. Cysto can pertain to the bladder, and urethrogram means it's an imaging to show the urethra. What that means is they give them some contrast, and then they watch them with X-ray peeing out, and they can see that. We don't really do that with ultrasound. We just look at the bladder before someone goes to the toilet and after someone goes to the toilet. We don't really examine, we can examine the urethra on, well, I suppose we can with the penis in males, but we can in females when we do these what we call transperineal scans, but I'm not going to go over those with you. It's a bit abstract and complex. I think when we first started, I showed you a transperineal scan and said this is what we need to know about the urethra. I'm certainly not showing you those images and getting you to understand those images in this unit because it's too abstract. Is trying to label the parts the best way to learn this? Trying to label the parts and think about where they're going to sit on images in 3 planes is the best way to learn. And think of not just labeling it, but what type of plane of image are you looking at, and where are the structures that you're labeling sitting relative to the other structures, because that's the understanding that you need to develop to help you to apply it to multiple different planes, but also to apply it to when you start scanning as well. I was breached, sorry mum, I know. Poor pregnancies. You'll learn a lot about pregnancies in other units, so we're just touching the surface of it here. I'm going to have to probably get going. Is there any questions before I go? I've just got to get to my doctor's appointment. It's really important. No? Okay. I will let you go. I'm sorry if I haven't been as on point today. I'm not feeling the best. I apologise. I just didn't want to not hold this for you today so that you can get on with your learning. I hope everyone's keeping well, and put any questions on the chat. That may be the best thing to do. I am travelling to Sydney tomorrow. I'm supposed to be, if I'm well enough to go, because I've got to present at a conference on Saturday. I'll just see if I get there. I don't want to have to pull out of it. Any other questions? No.
Thanks, Michelle.
That's okay. I will let you go. I'll jump on here. Good luck with looking over some of the abdomen stuff, and we're going to start diving deep. This wraps up our pelvis learning. I will revisit some of these later things that we've just skipped through when we go over the abdomen, but I think we've slowly gotten through the most important things in the pelvis now. Okay, I'll let you go. See you.